Assalamu alaikum. I'm Nighat Haider from the Department of Psychiatry and Behavioral Sciences, DHQ Hospital, Faisalabad. I hope all of you are safe in your homes and you're practicing social distancing and you're acting upon the principles of good hand hygiene. We were discussing psychological issues in special hospital settings, and we will resume from the previous one. We had already discussed CCU, the psychological issues that happens there and how to manage them. And today we will discuss intensive care unit. Psychological issues in intensive care units and their management. ICU is a special hospital setting that is usually not experienced by common man. A human being is a social animal and we are bound to some social norms. Everybody is like that, and the geological area we live in has peculiar social norms, and one of them is that we owe to pay a visit to a sick relative when he is hospitalized, and if we will not do that, it is considered as an inappropriate social behavior. So because people visit their ailing relatives in the indoor settings, they get familiar with the environment of the hospitals. The case is different in intensive care units because caregivers are not allowed to visit the ICU, the inside of the ICU, and this creates a sense of unease. This unfamiliarity creates a sense of unease in the patients and their caregivers as well, and this results in a range of psychological manifestations, and those psychological manifestations can be of varying severity, from very mild to very severe, from a very negligible anxiety to ICU psychosis or delirium. In ICU, patient has long periods of sensory deprivation at one hand and a kind of sensory overload on the other hand, and we will discuss in a few moments that how does this mechanism works. These two things basically creates ICU psychosis. It generates it. It is also called intensive care syndrome. And the symptoms or the signs are increased wakefulness, disorientation, visual hallucination, depression, social withdrawal, anxiety, delusions, and delirium. The combination of sensory overload and sensory deprivation is very important in creating these problems. The sensory overload comes from the noises of monitors, because the patient has to be monitored constantly. He's been intubated and he's attached to certain devices, and those devices have their beeps, their noises, and because of constant monitoring, medics and paramedics need to visit the beds frequently to monitor their vitals. So the activity of the staff also creates overload, a kind of sensory overload, and the ICU setting is constantly lit. It's full of light that never goes down, and there is a high level of activity. Paramedic staff, doctors, they're coming and going to the patient and to the other patients in the ICU. They're monitoring the vitals, they are monitoring the devices, and this is kind of sensory overload patient experiences. On the other hand, he is sensory deprived. How he is sensory deprived? Because he is immobile, he cannot move, he cannot change his postures himself, he cannot eat, drink, go to washroom, he cannot observe the environment outside the ICU. There are no windows or there are no calendars available there, and he's restrained, he's intubated, and the bandages, the monitors attached, that creates a sense of restraint, and this is the cause of sensory deprivation. And these two things, the combination of these two things, creates ICU syndrome. And what adds into it is the lack of familiar orienting objects such as clocks, calendars, windows, meals. Close proximity to other patients further worsen this condition. Normally, if you're not provided with the clocks or the calendars, you have a sense of time, sense of the trail of time through your windows, that the sun is rising, the sun is setting, it's noon, it's night, it's morning. You can track time. Then you can track time through your meals. I've been served breakfast, it must be morning. I've been served lunch, it must be this time. I've been served supper, this must be evening. So the patient in ICU is deprived of all these things. That is why he loses track of time. This lost track of time creates disorientation. And then there is a close proximity with other such patients. He see that other patients, they get worse, they get critical, and there is a kind of emergency there. He's been attended to, and that also creates psychological distress in the patient. An already distressed patient is exposed to constant attendance by physicians, nurses, and technicians. He or she also suffers sleep deprivation, physical and emotional pain of the disease, fear of mutilation or death, unfamiliar medical procedures. And in the part of the world we live in, most of the medical procedures are done without providing proper informational care and informed consent. So the patient feels minimal control on himself. He even loses control over his wrappings and his dressings. He even cannot dress up himself. He cannot go to washroom. He's catheterized most of the times. And all of this leads to sense of extreme stress and feeling of powerlessness and vulnerability. This vulnerability and this sense of powerlessness, it creates typical psychological reactions by many patients. They may get hyperactive, they may get aggressive, they may show anger, they may show anxiety, and the people working in intensive care units should not be surprised by that. You should expect these psychological reactions and you should be prepared for that, for their management. Now, how to intervene? Now you're familiar with what are the psychological reactions your patient admitted in an ICU can manifest, and what are the reactions his family may show. What are the interventions? The primary intervention is redesigning of ICU's architectural and administrative layout with the issues identified above in mind. This can greatly reduce the risk and frequency of ICU syndrome. But this is something that is not in the hands of a physician working there. This is something the administration or the management has to do, and it will take time. So we will see what you can do as a physician, as a healthcare provider on your own. There are certain steps that can be taken to improve psychological care of the patients in ICU, and this psychological care may be divided into two types. It may be focused on the inside of ICU and of course on the outside of ICU as well, because the psychological reaction will not only come from the patient, it will also come from the caregivers who are waiting outside the ICU, who have a sense of insecurity. What's happening with the patient now and what would happen with our patient in future. So being a physician in an ICU, you need to take care of both of these, the patient and the caregivers as well. Inside ICU, you can educate and prepare the patient. Always tell your patient what is the medical condition he is suffering from, what may be the causes, what he should expect in terms of treatment, and what may be the outcome. What is the prognosis? This is very important to tell your patient so that he may be prepared that I would be intubated, I would be monitored, I would be this, and that. Then use orientation devices, for example, clocks and calendars. Whenever you talk to the patient to monitor the vitals, to monitor the other medical indices, try to reconnect your patient with time. It's been morning, you're feeling fresh. How did you feel throughout the day? These hints of time will make your patient orient with time, so would help against disorientation. Try to minimize pain through pharmacological as well as non-pharmacological interventions. Pain is inevitable, but as a physician, you should be motivated to decrease that pain. Whether the patient is complaining or not, he is in pain. Try to minimize it. Try to soothe the patient through non-pharmacological interventions, and whenever there is a need for pharmacological interventions for pain, please do not hesitate for that. Be careful while discussing the patient's plight, assuming that the patient is unconscious, comatose, or sedated. This is a common mistake that basically happens in ICUs, that when a patient is being discussed with the colleagues, with the seniors, with the other medical and paramedical staff, the attending doctor, he forgets that the patient is present here. He assumes that the patient is not listening whatever I'm telling about him. And this is a horrible mistake. Always assume that whatever you're discussing about your patient at the bedside is being heard by the patient. Choose your words appropriately and carefully so that you can save your patient from emotional distress, you can save your patient from depression and hopelessness. Many patients in these states report having heard and painfully remember the negative and sometimes insensitive remarks of the healthcare staff. So, being a physician, you should be very much careful about what you say when standing in an ICU, and you should also monitor with the subordinate staff what kind of terms, what kind of expressions they are using about the patient. It should be appropriate, it should be scientific, and it should be carefully monitored. Reduce environmental stressors. There may be many environmental stressors in an ICU. and being a physician, you should be motivated to reduce them in the greater good of your patients. This was what a healthcare provider can do inside an ICU. What is the part of the deal for the tenants and for the caregivers who are staying outside the ICU? Designate a space for the family and the visitors. There should be a waiting room or a kind of a common room, a visitor's place where they can sit, where they can wait for the reports of their patient, and where they can discuss the prognosis of their patient with the doctors. Provide support and educate the family using informational care principles. Always keep the caregivers informed about the medical condition of your patient, and whenever this medical condition changes drastically, do not forget to get the caregivers informed about it. It will save you from many problems, from the distress and the anguish shown by the caregivers, from the violence they may create when they would suddenly heard that the patient has been expired. So keep them updated about the medical condition and the prognosis of your patient. Set up a counseling or solace room where those in distress can be attended to. The same space can be used to break bad news. So there should be a counseling room or a solace room where you can make the caregivers sit and you can discuss their concerns. You can give them emotional support, and whenever there is a need to break bad news about the diagnosis, about the expiry, about the other things, about any disability or permanent disability that has been happened to the patient, you can discuss that. You can break that bad news in the room. So there should be proper spaces. Hospital staff should be trained in counseling and non-pharmacological interventions in ICU, as it was already been discussed in CCU settings, and those non-pharmacological interventions may include deep breathing, relaxation exercises, basic informational care, distraction key techniques, and other things like that. They are non-pharmacological things, and they should be provided to the caregivers and to the tenants. And what are they? In fact, this has already been discussed. So that was for all for today. I hope now you can expect what are the psychological issues that a patient admitted in ICU may be experiencing, and what are the psychological manifestations the caregivers of a patient admitted in ICU may be experiencing, how they may manifest it, and how a healthcare provider should deal with these things pharmacologically and non-pharmacologically. So get prepared for that, and till then I wish you a good luck. God bless you.